Hi. We're going to get started. I'm Joan Mulvihill. I am the moderator for today's session, the IVI Webinar Series 2020. I think this is the third or fourth of mine to chair. And today we're going to be discussing the use of technology in the fight against COVID-19, which I'm sure many of you are really interested in and have probably read up quite a bit on already. But I am really delighted that we have such a great panel today. We've got three speakers: Gar Mac Críosta, who is the product manager within the HSE for the last number of months in relation to the COVID tracking app. I have signed on, no symptoms today, we're good to go. Colm Harte, Chief Technical Officer in NearForm, who are the Irish Cork Waterford-based company. Very remote, actually. A lot of you guys work remote anyway, so it's a moot point where you're based, but Waterford-based technology company who worked at the HSE on delivering this. And finally, Rosario Caruso, who is dialing in, I believe, from Sicily today to share with us his experiences from Italy in a public health perspective. I did remark to the guys that perhaps they had all started this process with a full head of hair and have torn it out over the last 3 or 4 months, but I have been reassured that this is a choice situation for all of them. I think it's just obviously a low maintenance choice. I was blonde at the start of all this. I am more, as I say, raccoon than cocoon right now, with loads of grey coming through, but hey, that's life. Anyway, before all of you go grey listening to me rabbiting on, we're going to kick off. Now, the guys have done what they do best, which is being very adaptive and agile, and have decided to ditch our carefully curated agenda for today. And Gar and Colm are actually going to do a two-hander presentation because it was very much a collaborative shared effort, and I suppose it gets Gar off the hook on having to do too many slides because he could probably talk for an hour on all of this. So this is our way of managing them. But just to draw your attention to the Q&A button at the bottom of your screen. I'm sure many of you have done these Zoom webinars before, but if you've got any questions for the guys, please do enter them there, and we will do a panel discussion with Q&A from you guys to these three at the end of all this. And of course, if you don't send in questions, I will be doing the questions. And that is an interrogation that I'm sure they do not want to go through. So we are not going to be doing the networking at the end. So we will get you out and back, or to whatever you were doing before this, to your inbox or whatever by 3:30. I'm thinking maybe 4 o'clock at the latest. So without further ado, Gar, Colm, which of you is going first? Gar, are you going first?
Yeah, that'll be me, I think. And so what I do at 3:30 is I start talking to Colm again. So this is an ongoing, yeah. So I guess this, and I'm not planning to go through a huge amount of slides here. They're kind of a guide if I need to jump in, if I have to. And Colm's going to chime in and jump in on different bits of this as well. What we're going to go through is it's kind of the story and the journey so far. For anybody based in Ireland, the COVID Tracker app was, I guess, much held and released in July. On the 7th of July, it was the official release date. We pushed it into the App Store and Play Store the night before, and people found it and started to download it pretty much straight away. So but again, this is one of those things. It's a really interesting project in many ways, but one of them was just the context around it, because we were all in the middle of the pandemic back in March, and this all kicked off back in, sorry, I'll just put the COVID slide up. We'll just leave that there for a while just to focus everybody's attention. But the origins of this started, it was actually on Paddy's Day that a conversation started around how do we use digital technologies to respond to COVID-19. And at that point in time, the HSE had stood up. Testing and tracing was in its infancy. We were standing up the back office piece of it, understanding what the service actually looked like, and there was the physical infrastructure of the testing centres and the Nightingale hospitals and all these other bits that were being stood up. So there was a huge amount of activity. So standing up call centres, standing up case management systems and everything else. But when it comes to contact tracing, people were beginning to look at this and look at the scale and look at, and I guess, Rosario, you can talk to some of the challenges faced in Italy, because we were looking to neighbours in Europe and internationally and looking at the curves and looking at what could happen in Ireland. And it was a glimpse into the future. And I guess we saw it as we were coming into late April and early May. But the goal was, and I'm going to skip over some of this stuff. So the goal was to try and figure out how do we use technology to respond to this and to do it in a way that makes sense. Now, as we stand or sit or wherever you are and whatever you're doing today, we kind of look back and it all makes sense. So you've got to look at this whole challenge through the lens of where we were at that time. So we now know a whole pile of things that we didn't know at that time. But as we look backwards, it seems all very common sense that we would end up exactly where we ended up with an app that does this, using the Google Apple API, et cetera, et cetera, et cetera. At that time, a lot of that didn't exist. So we'll just give you a sense of where that came from. This again, so the HSE was the lead agency involved, but it wasn't on its own. So there was the HSE, the Department of Health, Department of Public Expenditure, and Garda Síochána, Defence Forces were all involved in this. Ordnance Survey Ireland, the Central Statistics Office, and really there was we got pretty much help from anybody we needed help from. We got help from, and it was one of those unique situations where en masse government kind of came together and responded and acted together. So for anybody who's been involved in public sector projects in any size, shape or scale or description, they can tend to fall down on bureaucracy and protracted decision-making cycles and things like that. And I think there's a lot to be learned from situations like this, where you create the pressure and try and create a situation where this works. So I guess so this was me at the beginning, and then it became me and Colm. So I should add Colm into this one as well. As we began to kind of feel our way through how it is that we're going to solve this particular problem and I guess the problem, just to clarify what it was, it's how do we identify people who are too close for too long? That's it, right? And too close is within 2 meters, and too long is for over 15 minutes. And we didn't make up those numbers. So the European Centre for Disease Control have a case definition guideline, and the basis of that is 2 meters, 15 minutes. And we're all used to seeing the signs up all over the place, some of which are actually 2 meters and some of which don't look like 2 meters, but suggest that they might be 2 meters. So it's like, can you stay 2 meters apart? So the too close for too long it's a general purpose problem, and we're trying to figure that out. So how I ended up in this was actually another, Tim Willoughby is the head of innovation and digital service in Garda Síochána. He's the reason that I got involved, because he kind of put my name into the ring and said, I think we need some help, and I think Gar can help with this. So I was like, okay. So anyway, so this kind of started, and this graph is designed to kind of help understand where we were at that time, because we were still at the beginning of this cycle. And if you look as that graph goes up, and this is the graph of cases in Ireland, and the red line, unfortunately, is the graph of deaths in Ireland, right, as we go through this. This is what we were facing into. So at that point in time, we're pre. So and again, the context is set by how people are responding to it, their appetite to do different things, and the pressures on the system. So as we were facing into this, we're looking at limited number of ICU beds, limited number of testing capacity, limited number of hospital beds, hospitals having to restructure to respond to COVID, becoming a COVID hospital and a regular hospital as well, plus the deferral of elective surgeries and a whole pile of other things that were going on. And the media, and we were fixated every night. And I think it was the same from talking to teams from other countries. It was the same pretty much in every country. We became fixated on these morbid statistics that were released every night. So how many people died, how many new cases, and we all became obsessed with this. And that's kind of the framing around it. So we're still back early March. And again, it's one of those things that, sorry, I added the IVI template very late, as in 20 minutes before this presentation. So I will fix the slides before we publish them. But trying to figure out and trying to just submerge yourself in all of the information, because there was just emerging research going on in terms of how do we do this. And this is both how COVID works, but also people were doing research studies. So out of Wuhan, there was a ton of research came out of China. And then teams were working around the place in terms of how do we do something with it? How do we model it? What do we do with it? How do we respond to it? How do we do digital contact tracing? And we're all trying to figure it out. So there was a bunch of people, and so I'm not going to put my hand up and say, I did all of it. So we had a team of people, Colm included, and the NearForm team, the XBO team, the ISAS team, who were all part of a collective response to this. Plus all the teams who were working on this globally, we were all doing the same thing. So we're all trying to solve the same problem. So I don't think there's ever been a situation where globally you have a bunch of people trying to, in parallel, solve the same problem in a very short time frame. So it's a really unusual bit with that. And I guess one of the challenges with this is both the time around it, the pressures that were coming on top of it, but also it's emerging research. So a lot of the research that was coming out of China was unpeer reviewed. You're kind of you're trying to get a handle on what's going on and how it fits, right? And from a like a systemic response perspective, like pre-pandemic, we're into this like kind of big elongated program, and it's big program management, and that's how big programs work in the public sector. You move into in pandemic, all of a sudden it changes, and everybody's having to respond very quickly. We're having to do things very quickly. All of the pressures on the system change, and so there's some good stuff and some bad stuff. So the good stuff is we get stuff done very quickly. Everybody's very clear on what the purpose is. You kind of move forward on that. The bad stuff is it's all moving very quickly. You haven't got a handle on everything that's going on. So, and it is complex. So you don't know. So cause and effect aren't clear. So I can't say do this and do that, or do this and that will happen. Equally, if I spend too much time analyze something, that's not gonna, it doesn't help us over analyzing something in this situation, particularly where it's complex and emergent. So I think that was one of the things that came out of it. Talked about the too close for too long. I'm going to skip over some of this stuff, but I guess we were looking, and I have to be very careful how I say this. So VUCA, and I skipped over that bit at the start. So I think everybody's familiar with that term: volatile, uncertain, complex, and ambiguous. So 4 characteristics of these complex situations. And this I guess this situation and this scenario fitted people who were VUCA lovers, right? People who love VUCA. That's it. Okay. If you didn't really survive in this environment, because you had to be comfortable with the fact that you couldn't, not that you didn't know, but you couldn't know. You had to be certain that you were uncertain, and you had to kind of just keep going through on that. And what we ended up, and I think it was luck more than anything else, but the people who gravitated and put their hand up and said, yes, I want to be involved in this, were all people who embraced ambiguity. They're all people who are quite comfortable in the mess, quite comfortable in the chaos. They didn't need anybody to script their responses, and they knew what they were good at and knew their job. Right. And again, if I look at the process, because we ran, like, it was 100 days from start to finish, from when we started till when we released. And if you were to apply classic project management, it would have looked like chaos. But what it was more like was it was a giant, let's call it a dance. It was everybody dancing and trying to match the rhythm, not stand on each other's toes, and get stuff done. Right. And it really was about that. And so there wasn't kind of the big Gantt chart and checking in every day. So everybody checked in, but the check-ins were communication. So it wasn't checking in for its own sake. It wasn't status for its own sake. It was, I'll tell you what you need to know when you need to know it, or when I'm done. And then we were working off that and working together like that. So it's a very different environment and a very different way of working. Again, just to give a sense of where this all came from. So if you look at the too close for too long problem, so immediately people were thinking about, well, how do we do it? So you look at data sources. So where can we get data that can tell us about that? So telcos have data. Social media companies have data. So telcos can tell you, like, who was near what mast for at what time, because they've got it. So the call data records give you information like that. Can't we get it? Should we get it? If we ask people to check in, so one of the things, you'll see a QR code in the middle there. So with a QR code, do you get people to check in? So the New Zealand guys, actually, we had a call with New Zealand this morning. They started in a different place. They built a QR check-in system where you go and check in to, if you're going to a coffee shop. So for anybody who's done the bit where you're signing in, where you go for a coffee and you sign in a book to say, here's my name and here's my phone number, they solved that problem first. And they're now coming back to look at this problem, which is, how do we do too close for too long? So they were looking at where people were, potentially how long people were there for, but just knowing who was there at what time. We can also use so things like Bluetooth. So, and we'll come back to that one again, or we could use GPS. So GPS will tell me where you are. Obviously, difficulties working indoors, but GPS will tell me, and where we started with this. So this Paddy's Day, I got involved on the 18th. I think we've rewritten this app 3 times in 100 days, right? So the initial one was a geo-based big data play. And then we, as we went through this cycle, and like literally this was day by day. So we're starting to build it. We built something that worked. By the Friday of that week, we had then had conversations with the NHS, who were using Bluetooth for proximity, and I'll explain some of that stuff. And then on Friday night, Singapore released where is he? Hold on, I'll jump in here. So this guy became the most popular man in the world when it came to digital contact tracing. He's a guy called Jason Bay, and his team released Trace Together, which was the first Bluetooth proximity-based digital contact tracing app in the world at its time, like released at a national level. There had been prototypes and other ones around that, but we literally went in the space of 4 days to dramatically changing the architecture of this, and then trying to figure out, how do we do it, and can we do it reliably? So I'm going to go back up here for a second. So again, we didn't stop on that. So we kept multiple strands open at the same time. So we were still talking to the telco company, to the telcos, talking to the social media companies, like figuring this stuff out on their own, figuring out how do we use Bluetooth, how do we gauge distance, are there any references for this, are there any frameworks we can use, anything like that that we could use with that. And again, that began the process. Now, at this point in time, I think it was within 4 days of us starting, we had an immediate call for transparency, right? So somebody got wind that the HSE was building an app, and then straight away it was, tell us what you're doing, right? And that's a very difficult question to ask, because you're in this situation where the pressure is building, you don't really know what you're doing, and you're trying to search and you're in that squiggly line at the beginning of it where you're trying to figure out what's going on, right? You're trying to figure out options. So if I give you transparency, it looks like chaos, but it's actually a bunch of people who are trying to figure out and trying to gain some sense and learn what they don't know, to get to a point where something develops some form of coherence where it looks like it's potentially going to offer a solution, but without any certainty. So, and that pressure then followed us all the way through this. And I've never been involved in anything that had such, I think we hit the front pages of the Irish Sunday newspapers 4 weeks in a row, all right? And it was all demands for transparency and like whether we were doing it and how privacy intrusive this was going to be, and surveillance society, you name it, something came up. I think within 2 weeks of starting, we were already late. Like we hadn't delivered. So there was pressure building from lots of different places. And I think the media aspect of this can't be underestimated, because, and it's still continuing. So that this stuff and fielding questions around how this works, does this work? Like it's an ongoing piece with that. And every team who's involved in this is doing it globally. I'm going to take a breath for a minute. And Colm, do you want to jump in and from your experience in terms of where we ended up, is there anything in there that kind of...
Yeah, I mean, I'll talk a little bit kind of about the challenges we face just from a technical perspective. So when we first got involved, the big question was, can you get Bluetooth to work and to do proximity detection between two devices? And the expectation at the time was, well, Singapore have just released theirs. We think they're going to open source it. So the plan was initially, let's just, take what they've done. We'll build on top of it. This should be reasonably straightforward. Didn't work out that way. For various reasons, Singapore didn't open source immediately. It took them a few weeks to get to a point where they did. So we had moved ahead. Again, it sounded pretty simple, get two phones to talk to each other using Bluetooth. Initially, we started off using beacons. That worked, except we ran into lots of challenges on iOS devices because of limitations that Apple have in place. So if the app is open and in the foreground, everything worked as expected. As soon as you put the app into the background, you locked your phone. On iOS, for example, it stopped transmitting the beacon. Gar was able to get us a call set up with the HSE, or Gar and the HSE team, to get a call set up with Apple. So we spoke to Apple, we talked through what we were doing, here's the approach we're taking. Is there something else we can do differently? They suggested switching over to core Bluetooth, which is where you get devices to connect to each other, like your, say, Fitbit watch currently does to your phone, etc. So we abandoned beacons, we switched over to that. But again, we ran into very similar problems, that as soon as an iOS device was locked or the app was in the background, you had intermittent connectivity. So you couldn't reliably use it to do the whole 2 meter, 15-minute detection. You could probably detect when devices saw each other, but not that ongoing, continuous, repeatedly seeing each other. So that was a particular challenge we were really trying to face. We got to a point with that where we're kind of going, it works on Android. It doesn't really work on iOS. What do we want to do? Like, do we go live with this and we just target an Android audience, and we see later on if some solution comes from Apple that will allow us to do the iOS piece? There was a lot of these conversations going on. It was not an easy decision at that point, and it's around that time Apple and Google announced the fact that they were going to launch their exposure notification service, which would solve the Bluetooth problem. Well, solve it in terms of they would get two devices talking to each other and detecting each other and seeing each other. There were still problems with Bluetooth in relation to kind of accuracy of distance detection, and that's still an ongoing issue. But again, it was great that they were taking on that problem, because it means we didn't have to figure out all the calibration pieces across all the different Android handsets. And try and scale testing up to cover it's tens of thousands of combinations of Android hardware versus Android OS versions. So to cover that from a sort of testing perspective would have been pretty much impossible. And that was the start of the third rewrite of the application, which was basically switch the whole thing over to a decentralized architecture using the Apple and Google exposure notification service and go from there. Don't know where we are in the slides at the moment, Gar, but...
Yeah, I don't know where we are in the slides, but we can go backwards and forwards. It's I have a slide specifically for that.
Okay.
So basically we've skipped forward in time here, in that we're now up to the end of April. And I think one of the characteristics of this is the speed, the rapidity with which people were making decisions. So if you look in a lot of highly structured hierarchical organizations, the decision-making cycle tends to go up and then back down. So everything gets escalated up for somebody to make a decision. The difficulty with that is the person up high doesn't have context, may not have the skill to make the decision. And we were trying to make decisions which had, I guess, if you look at this, so if I follow it through, so the move from like a GPS based, so like a location based, time based system, moving that to Bluetooth based, that's a complex decision. So there's a couple of aspects to it. Now, one of them comes from a data protection and privacy perspective. So is it proportionate, right? So what's, from a data minimization perspective, what's the minimum amount of things or the minimum amount of information we need to have in order to help us do this and solve this particular problem? So that's the first lens that we put both solutions through to go, well, GPS will now squawk everybody's location around the country. So therefore I'm building up this profile of who's meeting who and where, right? Which is intrusive, right? And that's invasive. Versus Bluetooth. Now with Bluetooth, I've got a couple of options there, but Bluetooth is less invasive. I don't have to keep location. I don't have to do that. And I can make it more anonymous. So again, that's a constraint on the architecture to drive one decision over another. I think as we went through it, the next thing happened again, but there are consequences to each of those decisions. It's not as simple as we move forward and we do it. We lose something. So when we lose location, we lose the ability to identify hotspots from a geographical perspective. So epidemiologists love to see where is a hotspot occurring and mapping it out. So where's this locus of activity and where is this spawning out from and how do I track that and do something with that? So as we begin to go through it, you're seeing decision after decision, and there's an aspect to this where we need to be able to make the decision quickly, but also like I've tracked. So like one of the things that we did throughout this was keep a log of all decisions made. So we're keeping a log of all the decisions and the characteristics of those decisions. So is this one that we can reverse or not? Now, obviously over time, the more you commit to something, the more difficult it becomes to reverse, but the reversibility of is like a very specific characteristics of a decision. So moving from, we had committed to kind of location based, but we could back that out and within a couple of days we could move to something else. If we had to move off Bluetooth, we could have moved to something else, and then Bluetooth looked like it made it, I guess it offered us a solution to this. We then moved on to the next bit. Once we figured out that, and this was based on, so the guys in Singapore, and they were actually really helpful, but they had hit an impasse with the problem Colm described in that you couldn't wake iPhones up. They weren't working in the background reliably. And we got to a point where, and we were working with a German team, we were working with some guys in the US, we were working with the UK teams. Some, like, I mean, we had like the best and the brightest from an engineering perspective, trying to figure out how to hack the Bluetooth stack to make this work. And people coming up with the most ingenious ways of doing it. But I think it was the Friday before we decided to abandon the centralized model and move to the decentralized model. We got into this, we had a presentation from a group who said, we think we have this cracked, but basically what it meant was you had to stand on one foot, and on a Wednesday, if you faced west and it was raining, this would work. So it wasn't something that was certainly for me and for the other members of the team and the steering group, we didn't feel comfortable we could launch a national app that required this level of, I guess, wasn't going to be robust. So we were faced with making a decision, and that decision was, I think, and Colm can tell you like how many lines of code, but we reckon it was about 10,000 lines of code need to be ripped out of the app. And then we're having to make a decision to move over to something that Apple and Google had separately implemented. Nobody had seen at this point because it wasn't released, and nobody had built anything on top of it. So we were kind of making a decision to take a dependency on Apple and Google to do what they were committing to do to get our deliverable out the door. So that's a big one to make, because you've got like there's a multiple of different things going on there. The other side to this, and I guess one of the debates that raged back in April, it all seems like it's in the past now, but it's the centralized versus decentralized, was this giant argument of like how this should work or how this wouldn't work. In a centralized, so if you do contact tracing and you're a public health professional, you've got an index patient. So Gar gets sick, Gar's been in contact with Colm, I'm the index patient, Colm is a close contact, and I follow it through. So if you talk to any public health professional, they think in terms of an index patient. So I know who that is and I understand the graph and the connections between them. And then I trace that and I follow it through. The problem with that is you're building up at a national scale. So that works for smaller outbreaks of things, because, and it would work for a bigger outbreak of things. And there's nothing wrong with it per se, but at a population scale, when I'm rolling it out to a population or globally, now all of a sudden I'm building graphs of connections out between people. And I can map those graphs, and I understand that I met Colm and Colm met Rosario and Rosario met Paul, et cetera, et cetera, et cetera. And then somebody met Joan along the way. And that creates a privacy problem. But actually the problem is do I want to have, not having that data? So it's not the approach towards it, because this is kind of baked into public health and the science of public health. It's how they do it. But when we're looking at deploying something like this, the argument became centralized bad, decentralized good. And it became a very kind of, I guess, a black and white one. And it's much more like it's much more nuanced than that. So you can't see it in those terms. But we ended up in this battle because we had followed the actually advice of a privacy professional who subsequently decided to change his mind and say decentralized good and what you're doing is bad, even though we'd taken advice to say what you're doing is what the Singapore guys did is fine. So we were following a model that we thought we were on safe ground from a data protection perspective. Turns out the world had turned, and it was literally within a couple of weeks, it had turned around and we became decentralized. Now, the decentralized thing, and I guess the thing to note for this is, you have to think through this process. So we're in the middle of it. We had colleagues from public health and epidemiology and HSE and Department of Health. We're bringing them on this journey, explaining what we can do and the data that we will have and how this thing will work from an operational perspective. And the app itself needs to be seen in the context of contact tracing from the HSE overall. So it augments the existing system. It doesn't replace it, and it doesn't work on its own. It only works in the context of something else. So when people talk about contact tracing, it's not the app, it's the system of contact tracing, from identifying individuals, testing them all the way through to outcomes, identifying close contacts and interviewing them. So we were building something that integrated with that. But that whole back office system is based on knowing who the index patient is. I identify you, I identify and I interview you, I find out who you've been in contact with, and I follow that path through, and then I get those people tested, et cetera, and you rinse and repeat and you keep doing it. We had been following that model, and the centralized model perfectly fits in there, and that I can give you the index patient and tell you who they were in contact with broadly and notify those people. The decentralized model, I then lose the ability to know who that person is. I know, and actually the HSE knows nothing. So if somebody has gone onto and so you can go onto the app today, you can go through the onboarding process, not share metrics, not provide a phone number, not do anything. You're completely anonymous as far as the HSE is concerned, but you can be notified if you've got a close contact event, right? So you can, but even if we do figure out, or if you do choose to share a phone number with us, we don't know who you are, we don't know your name, we don't know where you are, and we don't know who you were in contact with. And if you test positive and you share these random identifiers that you collect on your phone, you generate them and then you collect them from other phones you interact with, we still don't know who's been in contact with who. So it's privacy preserving in the extreme. So, I mean, this is one of the weird, like if you look at the data that we have, we've got so little data. Like, I mean, literally this is the smallest data set that's had the most scrutiny of anything I've ever seen, right? Because we have a tiny amount of data, and it doesn't, and like the vast majority of this data is non-identifiable. So it doesn't identify any individual. So it's not PII data or classified as PII data. It's literally just random identifiers that can be connected back. And when somebody downloads them to their phone, it can tell them you had a close contact event. It doesn't say who, it doesn't say where. And that's kind of the key to it. But the problem then is having to, and for anybody who's watching the Irish news, so Sarah Doyle has been on a number of times. So Sarah Doyle is the head of public health for HSE. So, hey, Sarah, you know the way I told you we were going to have an index patient? Well, now you're not. So that was an interesting conversation as we began. And I guess it is something for any team that's working on this, that they're having the same conversations with their public health colleagues to try and figure out, well, what can we have? So you go from having data or knowing what data you can have and asking for the data you want to have, to saying, well, what data can I have? What can I know? What can't I know? And you're working through that. So it's data minimization. I think people have been talking about privacy by design for a long time. This is the first example, from my experience anyway, this is the first one where like literally every decision that was made, everything that was done, everything in the app was put through the privacy lens first and foremost. And I know to the frustration of both myself and Colm, but I think ultimately it was like each and everything went through that lens first. So user experience then came on top of it, but it sometimes suffered as a result of focusing on the privacy and the privacy preserving nature of it. But the goal was to try and get something out the door that could satisfy the needs and satisfy the requirements of it. Anyway, so that's kind of the overall story. I think where we are now, I'm going to skip forward in this because we obviously, data protection jiu-jitsu. Yeah, we had a lot of media coverage. Let's just go with that, right? We're ready to go. So 100 days from the 18th of March, app is ready to go. Like as in, it's gone through the review process with Apple and Google. We're ready to push the button and it's ready to go. unfortunately, if anybody remembers back to June, and it's fortunate. This is not a criticism of government, but we were in the middle of, we'd had elections in February, I think it was, and government formation talks had been going on all the way through this. So we had an interim government subject to new government formation. So at that point in time, we were down to the decision to actually go live with this, because this was at a national scale and at a government level, it was seen to be putting health in people's pockets. So if we're looking at that mass scale of adoption, we're kind of working through this process. We then fell victim to a timing challenge, which is the last government decided not to make the last decision it made something that the next government may not have made. So we got kicked from cabinet meeting to cabinet meeting to cabinet meeting. Then the government dissolved, new government formed, and then we're into the next government. And then that goes back around again to having to explain to a new set of ministers how this whole thing works. And so this was the very first formal decision that this current government made, was to go live with this app. So, which is it's an unenviable position to put a brand new set of people into, and to try and explain something that's quite complex and had received a ton of media attention. I think the other thing to, to call everybody's attention to was that as we looked internationally, there were disaster after disaster happening in country by country. There were projects like this that were failing spectacularly, or had failed already. So there were these stories coming around, and you can imagine that if you're sitting in that seat and you're the Minister for Health, or you're the Taoiseach, and you're sitting there and you're trying to make this decision, you're drawn to see what's happened next door. So how did it work in the UK? And we're like, okay. Now they have just released their version of the app now, and it's completely redesigned. It's similar, and we worked with them, we helped them, they've helped us, we've helped them, and this has been part of a global collaboration. But basically what ended up was the government formation piece held us up. So we were kind of into government formation. 110 days from start to finish, we went live, which was on 6th of July. Myself and Colm were pushing things into the App Store. Is it there yet? And then things kicked off. So since then, we have had, as of today, it's north of 1.6 million people have completed the onboarding process. We've had, I think so far, we've had over 450 people have received close contact notifications. We've had 200 plus people who are like app users who've tested positive and uploaded and shared diagnosis keys with the system. And it's beginning to show progress. So it's working through it and we can see it. And I think the challenge we had was that the target, so it's an easy target for certain groups to pick at, right, and to point at. So privacy advocates, civil liberties, and they're right in terms of the challenges that they're trying to address. The problem is we're not trying to balance off. We're not trying to say privacy is the only thing. This is not a privacy pandemic. This is a COVID-19 pandemic. So we're in the situation of trying to respond to that and having to trade off against these things. If you're only interested in privacy, you don't trade off against anything else. You're not trading off against the economics of it, or getting society back up and running, or the health of the population. You're just worried about privacy. So we're trying to balance all of these things as we go along. And the target shifted from, once we passed the privacy hurdle, and the privacy hurdle was the first thing, then it moved on to efficacy. Does it work? And now we're moving into that stage of it. Does it work now? It's up and running for 2 months. What's happened? So I know people are testing or have received close contact notifications, and we're moving on to the next piece. So I guess that's the next stage for us, is looking at the efficacy and outcomes of this overall. And over the next couple of weeks, we will be releasing data on that, and just to try and get a sense of of how this is working overall. And it's not for us to get a sense, it's to share that with people, to say, this is a solution that has, and we're sharing this data with other countries as well and feeding from them, because we're all building on the same core architecture and core platform. If it works in one place, it works everywhere, right? So it's a similar solution, it's a similar thing. And we're going through that process and doing it. So we know that as a solution, this works and can add value. The question is now, how do we use it better and use it more effectively? So this is kind of the roadmap for us now, is figuring out how best do we bring this together, and how else do we use it, and where do we do it? And I think I'm going to ask Colm to come back in now, because I think one of the interesting pieces was we had done it here, and there was a call from a transparency perspective to, we demand to see your code. So we published the code, and it was the first ever open source project that the HSE had ever been involved in. So it's up in GitHub, we published it up there. A lot of people looked at it, right, just to try and figure out, and did teardowns on it from a security and privacy perspective, and said, yeah, all good. Then other countries began to pick it up. So, and Colm can talk about some of the other ones, but like Northern Ireland and Scotland are two that are building on the code base. Pennsylvania in the US is also building on this, so it's the same code base. It's effectively the same, or variations of the same app. they're all subtly different because they've got to fit into how their public health authorities want to respond to this. But Colm, do you want to give, because you've been involved now in way more than just the Irish one at this point?
Yeah, so I mean, what we did was we took the code base that had been created for the HSE, and actually before the HSE went live, Gibraltar also built up the same code base and went live as well. And again, from a specific country perspective, they all have very specific needs from the app itself. So the backend is consistent across everything, but the specific apps for each country are very unique. So the HSE app was tailored towards the needs specifically around Ireland. So it has a symptom checker, it has the stats around COVID-19, obviously has the contact tracing. Contact tracing they all have. Gibraltar went with a different model. They only wanted contact tracing. They didn't want any other functionality in the app. Northern Ireland, again, if you look at the Northern Ireland app, it's again a completely different interface to what we have in the Republic. And we're seeing that kind of pattern repeated as we engage with some of the US states as well. I mean, they all have the same core functionality. They all do contact tracing. Some of them want things like the stats around COVID-19 specific to their state or country. And some do want the symptom checker. But in the US, for example, the symptom checker changes to follow the CDC guidelines, as opposed to the guidelines we have within the HSE app. So you have all those subtle variations on the app itself. The code base has been also put into the Linux Foundation Public Health as COVID Green. And that's driving a lot of things from there. So all these apps are building on top of that one code base. They're all getting the benefit of any changes and improvements that are happening as a result of implementations in other states or other countries. And it's all feeding back into that one source. So it's very transparent, it's very public. Anybody can go look at the code, anybody can comment on the code, feed into it, open issues, create a PR. So from a transparency perspective, like, you can clearly see how the app works, how the backend works, what data is actually stored, how long data is held for. As Gar mentioned, we actually hold a very small amount of data. The apps itself, we don't use things like third-party analytics, again, just purely from a privacy perspective, that just raises too many questions about what data is that package collecting. Same with things like crash analytics. We don't have those in the app, again, just purely from a privacy perspective. So a little bit unusual from that perspective in terms of building a mobile app, because normally you want to know as much as information as possible, how the user's interacting with your app, where they're getting stuck, which pieces they're spending more time on, what features get used the most. But because you're putting that privacy preserving hat on as the most important thing, all that kind of goes to the wayside. So they are trade-offs, as Gar mentioned. But overall, it's been hugely successful. The uptake in Ireland has been incredible. I do remember that night of the 6th, Gar, when we first put it live, and we were myself and Gar were downloading the app just to make sure it still worked. It'd been a couple of weeks since it actually had gone through the approval process. And after about 10 minutes, I suddenly realized that the graph of user registration was going up, which was we're first kind of looking at each other going, what's happening here? How could this suddenly be spiking? But I think within 20 minutes of it actually going live in the App Store, it was on social media. So I think by the end of that night, we had over 20,000 installations. By 7 a.m. the next day, there was over 50,000. And by 3 p.m. on the day of launch, it was over 500,000.
It was
so
by the time Paul Reid, the CEO of the HSE, put up to make a speech in the morning at our launch.
Yeah.
So at that point, and he was constantly being fed numbers. Where are we at now? And it was like, will we make it to 300,000 before the end? Like before I get up, it was like probably. And again, we had 1 million people complete the onboarding process within 48 hours. So it was like this sharp curve that it just went up, and we've seen a gradual increase since then. So we keep gaining users, and I think part of the challenge now is it's looking at the gaps and looking at the holes. So from an inclusion perspective, who doesn't have it, and how do we help them, and what else? So we're looking at other options and other solutions. So wearables being one. So where do they fit, and who do they fit for, and what could we do with them? So there's a whole pile of other things we can do with this. But again, the framing for this app is as a pandemic response app. And I think that's one of the key bits, is that it's to help us respond to the pandemic. It's not a one thing. It's not just digital contact tracing. It's now a channel in terms of how do we communicate with people? How do we give you the information that we need? So we've got a release coming out next week, and it's based on feedback that we've received from users, which is all around. So we love the fact that you're providing statistics and information in the app, but can you give us more timely information? So yeah. So that's kind of, I guess that's what next for us is that we have a roadmap that kind of stretches from here out till probably Christmas at this point, in terms of, I'm just looking at it. Colm has to build this all. I just have to dream up some of it. So we've got it's probably unfair, but as we're going through this, it is being driven. So it's bounded by helping us respond to COVID-19. So we can't stretch outside of it, nor do we want to. So this isn't a general purpose health app from a HSE perspective. But at the same time, it's figuring out how do we plug into that and looking what other countries are doing. So we had a call with New Zealand this morning, and they're using the QR codes to check into places. So there are things like this where we may not do that, we might. So it's something that we'll throw on the table and figure out. So I'm just, I guess that's kind of the story to date. And I know that's kind of a whistle stop piece, and I wanted to leave it open for Joan to come in and do some Q&A on it. But I see one question from Gianluca. And thank you for calling me doctor. I'm not a doctor by any stretch, either a PhD or a medical doctor. But do you think in your contact tracing about different countries based on? So one of the first things, so this is about will contact tracing apps from different countries talk to each other? So we've actually the first anywhere globally who has interoperability up and running. So the Northern Ireland app and the Ireland app talk to each other. So if you go into Northern Ireland and you've got the COVID tracker app, and the Stop COVID app NI, it's Stop COVID NI, isn't it, Colm?
Stop COVID NI, yeah.
They will exchange tokens, so they'll exchange random IDs across it, and then they work. So if a notification happens, we're sharing. So there's an Island of Ireland registry that all of the diagnosis keys get shared. They get shared into that. These are all anonymous. They're effectively public keys. They're shared to every device. And if somebody tests positive in Northern Ireland, their keys can be downloaded by somebody in the Republic of Ireland, and that will be shared. This morning I spent on a call so there's an EU program and an EU initiative where we'll be doing this at an EU level. So we're putting in effectively a federation gateway service to allow and enable countries to exchange keys with each other. And there's a pattern, a country of interest pattern. So you don't get everything, but we will get keys that you designate from different countries. So if you're traveling, you'll be able to download keys from the country you're traveling to. And if somebody's traveled to Ireland, then if they test positive, they'll be shared with us in Ireland. So the interoperability piece in Europe, and certainly I guess EEA plus UK and Switzerland, Norway, others, that'll be solved probably over the next couple of months. Like, we're looking to go live with this. I'd say we're in a pilot process at the moment, so it's going to be into September. And then, and again, this is about reopening and making sure that we can open up safely and that we can share that information and do it in a privacy preserving way. The other thing then will be with the US as well. As we begin to open up there, it's figuring out how do we do it. And they're looking at a national service that's going to be hosted independently around how do they do. So in the US, it's going to be state by state, but then there's going to be national pieces of the puzzle that kind of tie it together. So we're beginning to kind of open this up, and that's going to happen over the next months. So Joan, I'm going to hand over to you and I'm not sure how much time we've got left in our slot, about 8 minutes, I think. Do you want to just jump in and?
Yes, I'm just here unmuting myself and starting my video, which may or may not start. Anyway, gosh, guys, thank you so much for that. Like, I mean, I knew some of the story just from knowing you, but that's a lot more. I'm not going to do questions now because I am very conscious that we want to bring Rosario in and to start the Q&A at the end. But I'm going to leave a question for Colm and Gar to reflect on. Very serious question. When they make the imitation game movie of what you guys have done in the last, 5 months, I want you to come back to me when we start the Q&A and tell me who you'd like to play you in the movie. So that's my only ridiculous question to ask you for right now to reflect on. And I'm going to move on to Rosario.
I'm there, Joan. It's Woody Harrelson.
In your dreams. Okay, think on that. I'm going to hand over to Rosario. I think you've got slides there as well. So for anyone who's just dialed in belatedly, Rosario is a doctor, so I'm going to say Dr. Rosario Caruso, Director of the Unit of Health Professionals Research and Innovation I'm not going to say this correctly. Policy, you do it better than I will. In Milan, in Italy. I'm going to hand over to you, Rosario. Thank you so much for joining us.
Thank you for your kind invitation. I'm actually very pleased to be with you in this webinar this afternoon, and I actually enjoyed also the presentation of the colleagues Gar Mac Críosta and Colm Harte. I actually enjoyed your presentation. My role in this webinar could be in bringing a perspective of the side of the healthcare providers that we are users of technology in the battle against COVID-19. And I would like to just to share with you some of our challenges, experienced challenges with tech and the open challenges that we are facing with. Maybe I cannot share my screen as there is the presentation.
Gar, do you need to take yours down, or Paul, do you have?
Okay, great.
There we go.
Now, I am able to share my slides.
I'll go back to mute.
Very good. So my agenda for this presentation is going to cover the following topics. I would like to share with you some information about the scenario that we had before the outbreak and what kind of lessons we learned, some insights from our research, and some concluding remarks. The focus of the presentation will be the tech, the use of technology in facing the challenges brought by COVID-19. So this is a picture that I used to explain in roughly 1.5 hours to my students, but I'm just going to say just one thing about this picture. The scenario that we had when the COVID-19 pandemic started was very complex with very diverse and heterogeneous factors that actually that far are characterizing the healthcare scenario. At the beginning, as healthcare providers, we thought that new technology and methods were related about reliability of our approach, but this is not true, because if you see the picture, it's a complex and integrated interchange of elements about different factors in the that are characterizing the healthcare scenario. So technology is actually triggering everything: reliability of our approach, the dynamicity, the access to services, and sustainability. What we know is that the kind of competence that we have to keep in mind when we practice our daily activities is a competence that should be open to embrace diverse elements coming from different professionals and backgrounds, such as colleagues involved in developing technology. So I work here in the south area of Milan, and the red dots are the facilities of GSD, Gruppo Ospedaliero San Donato in Italian. And the first outbreak that we have experienced was in this area of the Lombardy region in Milan. At the beginning of January, the outbreak in China was the first, the beginning, the trigger to start some precautions. And but the first case, confirmed case, was confirmed on 22nd February. The first outbreak involved the 19th municipality here, and the second at the 22nd February. And at the beginning of March, a second outbreak in this area, Bergamo and Brescia, involved other municipalities. So we were in the between of these two outbreaks in the initial at the beginning of March. So the national lockdown in Italy was performed in the 9th of March, as many outbreaks were started to involve different regions. And you can see the numbers of our procedures here. So you can imagine that our activity and our endeavors towards reorganize the services to face with the horrific challenges and demands by COVID-19 These numbers was, of course, redirected to reorganize all our activities. We was a stark warning to the world when this pandemic started, as we was the second nation actually interested by a bad wave of outbreak. What we learned is that the restrictive measures showed to be effective, but some challenges are still open. In my opinion, this is my personal opinion as researcher, contact tracing, as the colleagues before my presentation explained it, contact tracing is not only an app, it's a system. So we as healthcare providers, the public health officers and so on, have to be involved in this system. It's not just an app, it's a complex system that have to work. So contact identification, listing, follow-up, it's an open challenge. The behavioral change, on the other hand, and the continuum of care, because COVID-19 does not mean that the other disease of population disappeared. COVID-19 increased the burden of healthcare needs in our population, but it it triggered a number of challenges. For instance, the remote monitoring, remote education and follow-up of our patient were triggered by this situation, of course, as we had to follow the patients that were not infected by COVID-19, but that have a continuous need of monitoring and so on. The element that I think could be a negative predictor of success in these challenges is the mistrust in biomedical research, the public mistrust in biomedical research. Technology is a linchpin for all these challenges, and I would like to share with you some insights that arise from some researches we performed during the first wave of outbreak that we had in Italy. And for instance, this is a study, the data in the slides reported a study on patients with cancer, and 3 out of 4 of these patients were not able to attend the follow-up visits. They experienced an increased fear that their cancer would not be regarded as important due to the outspread of the COVID-19. So for this reason, it was fundamental to think some digital solution to stay close with our patients. And the next step of this kind of approach will be focused in identifying the more effective digital solution that can allow us to do our job in an efficient way. This is quite alarming in my opinion. This data highlight, this data is not alarming. This data highlight how theoretical concept that we call health engagement, when we measure health engagement and risk and protective factors of post-traumatic stress disorders, we found that health engagement actually have the ability to decrease the effects of the negative, the risk factors of post-traumatic stress disorder, and to enhance the protective factors. We use this study as a proxy of the general population. This study was focused on university students. What we know is that people is surrounded by information about the pandemic, is surrounded by information that bring different messages, sometimes also messages with diverse perspective and so on. So what we think about this study corroborated one hypothesis, that health engagement is surely important, but the question is, how can we work to enhance the levels of health engagement in our population, or in specific subgroup of the general population, such as in this case among university students? So we believe, we theorize that digital health literacy could be the most powerful in this scenario characterized by infodemic, by diverse information about COVID-19 that people can retrieve on the web. In this scenario, people have to be supported in retrieving and critically evaluating the available information. For this reason, theoretically, this ability enables people to perform this, what we do as researcher, because if I think about my perspective, of course, my mindset is oriented to define to find out a hierarchy among the information, but general public have not this kind of mindset. So some digital competencies and the theoretical construct of digital health literacy could actually be a very powerful element to enhance the health engagement levels among general population. Before COVID-19 outbreak, we started this kind of discussion also with colleagues from the IBI. For instance, I started this discussion with Marco Alfano before this, starting the pandemic, and find which kind of digital solution could be used and could be tested as effective in enhancing measured levels of engagement, digital health literacy, and so on, is paramount, as we have to integrate these approaches in our daily practice, not just as research, but in our daily practice to ensure a sound care delivery. We performed other two studies published in European Journal of Epidemiology with Catholic University of Sacred Heart in Milan, and we found that roughly 40% of our sample have a mistrust in biomedical research. I believe that the forefront challenge in the battle against COVID-19 in Italy is the mistrust in biomedical research. Regarding contact tracing, in Italy we have contact tracing is something that, in my opinion, should be understood within the framework, more complex than only tracing, of testing, treating people, and this is particularly something that is related to the healthcare sector, and tracing. So this complex framework, testing, treating, and tracing, is the compass that we have to use. What we are experiencing right now with the Immuni app in Italy, which is an app that was developed based on the experience on Singapore, as previously explained, is that roughly 5 million Italians downloaded the app. What does it mean? That 5 million represent roughly the 8-9% of the Italian targeted population. This app could be downloaded in Android 6 and iOS 13 systems. And if we consider the targeted population with this system, we can say that this app is now was downloaded by roughly 14% of the population that have Android 6 and iOS 13. Yes, as explained before, this app was consistent with the GDPR European law, so the privacy, as it uses low energy Bluetooth technology, creating pseudo ID to ensure the privacy of the users, exactly in a consistent way with the system explained by the colleagues in the previous presentations. So, public health, in my opinion, should consider more and more this fact, the fact that mistrust is a pitfall in the success of each kind of initiative related to increasing the connection among professionals, among people, and so on. And again, if we think that, in my opinion, if we consider the health of the people, now a new outcome, a new patient outcome, in my opinion, is actually the digital health literacy of people. So digital health literacy should be considered as pivotal for strengthening the partnership among researchers and the partnership clinicians users. In my opinion, when we have to face a problem, the problem should be framed using different perspectives. What does it mean? It means that as healthcare providers, we, in many cases, the traditional approach is start to think about multi-professional, multidisciplinary approaches considering the healthcare arena, the healthcare sector. But now I think it's very important to include in our problem assessment, problem identification of the problem and identification of the possible solution, other professionals such as the colleagues involved in the technology development and so on. Because this kind of triangulation works actually as the GPS. We have to triangulate the problem and we have to be precise in identify solutions. So I believe this approach should be extended also involving professionals also outside the healthcare providers. In our educations, this is one of the problems that we experience is that each different healthcare professional is generally educated as a standalone professional. When they go in the market arena, they have to work together. I think that now the scenario is also more complex because we have to work close with engineers, we have to work close with physics and so on. And I think that we should find a way to put in the early stage of the education a way to enhance a mindset oriented to the multidisciplinarity, including not only the healthcare profession with a broader perspective, including also the colleagues that develop and study technology. Because when we speak, we should be aligned about the language. We should understand the problems that we ask for, the problems that we see, and the solution that we see to solve the problems that we experience. So we should start to work close and find a way to communicate. I'm not speaking about the language. As you know, from my Italian accent, the problem is not the language. The problem is find a way to create an ecosystem that allow a very proficient and sound different combination of perspective among professionals. So, some concluding remarks from my experience and from my perspective. I think that technology is an actual linchpin for providing connection between and within different professionals and the general public. Digital solutions require high levels of trust in biomedical research and adequate levels of digital health literacy. I believe this is true. We are corroborating this kind of hypothesis, but I find that this, the digital health literacy and consequently health engagement are actually patient outcome. Adequate level of digital health literacy require multi-layer strategies. And what I can say is that COVID-19 is just triggering what we felt even before the COVID-19. It's thus triggering choices, strategies, developments. My wish is to shift from the horrific of the COVID-19 to the terrific war of the use of technology in the healthcare sector and also in a broader perspective. And it should be upon all of us, as we have the duty to keep in mind that different professionals, different disciplines, different kind of researcher should start to attend the same arenas. That's my message. Thank you for listening.
Thank you very much for that, Rosario. That was really interesting. And actually, it was just listening to you, it was great just to have that perspective of somebody who's looking at it very much from a public health point of view. And that's not to take from the fact that Gar is working at the moment with the health service executive here, but directly in relation to public health. And obviously, everyone here was watching what was going on for Italy. I can only imagine, I can't even imagine how difficult that must have been for you during that time. So I'm sure we all feel for everybody in Italy. When I really say thank you so much for sharing your experience, which I'm sure was challenging. If the guys want to turn their cameras back on or unmute themselves, I don't know, Colm, if you've decided who's playing you in a movie yet?
Yep, that was very easy. George Clooney, similar hairstyle and stuff, you know?
That's what I was thinking. I was going to go down that route, but you know, the pressure.
It's all about the hair.
And where's himself? Is Woody Harrelson coming back? Gar? No, he'll be there. I think he's answering questions.
Gar's here.
Oh,
Yes,
Gar.
I'm going to stick with Woody Harrelson. Just
yeah.
He's already bald. He doesn't need to do anything. He's got a similar shape. Nose might be slightly bigger or smaller, but it'll do the job.
The only reason you're saying Woody Harrelson is I know you're a big basketball fan and you're just going, white men can't jump, and you're stuck with that forever. It's dating. Anyway, speaking of, moving on from movie references, something that struck me, Gar, that you had said earlier on, and this is to all of you, it's a closed question, it's a terrible question. Globally, everyone is trying to solve the same problem at the same time in a short time. And the person I feel for in all of this is poor Greta Thunberg.
Yeah.
You know, like, I mean, this is, you know, we have learned lessons from this in relation to other global challenges. Global warming, climate change may be one of them, but it does show what is possible when you're acting like your house is on fire. And I think that was something that I really took from this in terms of your approach, but also what's going on globally, and indeed the skeptics on climate change. Some of them are the same skeptics that we have on global pandemics also, but that's an argument and a discussion for another day. Gar is a great man for drawing pictures, and I do some doodling myself when I'm listening and trying to formulate what you're saying. And it struck me that there was two common threads, one half being the technology piece and the other that I can encompass under the one word, which is trust. And trust operating at multiple trust levels. So there was trust in relation to privacy, and that plays to what Rosario is saying, really, you know, in terms of, you know, citizens trusting in the technology and trusting in digital health, and that whole privacy piece, whether that is led by ordinary citizens who aren't really thinking about it that much until somebody wants to fake news it or make some big issue that may or may not be there. Then there's the trust around transparency, and, you know, there will always be challenges to anything that's developed, and they'll say, you know, I wanted to see all your lines of code, and, you know, and the fact that you documented every single decision that you made throughout that with the justification lest somebody wants to make a problem. There's trust, transparency issues there beyond citizen privacy. And then the one that I thought was really interesting was trust in terms of empowerment. And, you know, you're working in, you know, Gar, Colm, you guys come at this from a technical expertise, and with the best will in the world, you know, the HSE is running multiple systems, thousands of different, you know, applications and services all of the time, probably under-resourced in the terms of technology. And, you know, you've got ministers who are not techies either, and there has to be a huge amount of trust to empower a disparate group of people to go and turn something around that quickly. Colm is half smiling there. So I'm going to go to him first while Gar is looking at the skies praying for divine intervention.
I'm looking up. I've escalated this question.
So I suppose when we got involved, like one of the initial asks was, how fast can you get us an app like that will run end to end? Doesn't have to do everything, but we want to see something. And that initial turnaround time was 3 days, right, to get something that worked on a phone. It wasn't doing contact tracing, but it was the app UX and kind of UI at that stage. So I guess it was about us verifying that we can deliver, we can move quickly. You know, again, as Gar was kind of talking to, like there was a lot of chaos at the start. You had to be willing to embrace that. So the normal way you might structure a project or plan a project, it wouldn't have worked. We'd still be back at the start trying to get something done. So it was very much about finding a group of people that were just willing to jump in and do things.
Yeah. And I think that, can I just chime in on that, because it's one of the things that I think isn't done enough. It's that bit of, because seeing is believing. We've all seen we've all sat through too many PowerPoint decks talking about the wonderful world that will be there once we've spent all the money and done all this work, and it takes forever. But seeing is believing. So if you want to build trust and confidence with any particular stakeholder, I can then walk into somebody and go, this is what it's going to look like, and here it is on your phone. It's a very different conversation then. This is what it will look like when we're done, this is it. And then constantly reinforcing that message over and over. And it is that seeing is believing piece. And that, I think, is fundamentally different, because if you're into and I've been involved in some ridiculous projects which are multi-year, and nothing happens for, like, I did one government project that was 4 years running when I started on it, right? So it didn't go live for another 2 years after that. So that's 6 years from start to finish. That's a very different mindset to come from it.
It's also a very different cost base, I'm sure. Like, one thing that you all have to be congratulated on is the cost at which the project was delivered. I think I understand something like the cost per user is something minuscule, really, when you consider overall. And I think anyone looking from the outside, they see 800,000 and they see a lot. But I mean, I'm sure that covered a lot of consulting time around GDPR and privacy and all of those hours that go into that as well.
So I think the thing to, like, I guess separately to that is the fact that this is now being used elsewhere. Mm-hmm. Is when you start factoring in those, and when you start factoring in the overall number of people who will be using and building on top of this thing that we have built, that really puts it into, like, that investment in that. So, and that investment, I'm laughing as you say that. So who are you congratulating, the HSE or NearForm? It's a very different conversation. I think as those conversations unfolded, it was, so numbers were being reported elsewhere, and there was a running joke internally. It was like, look what you could have charged.
You know what, you'll get the royalties from the movie. That's all I can say.
Of course.
You'll keep going down the movie route and get your royalties from that.
Yeah. But I think this is, I mean, in terms of value for money, it's that this is, and again, we won't see it because there's the initial piece of how much do you spend to get you where you need to get to? And then what do you get out of that? So like, I guess so my history with IVI, and a good chunk of what IVI has been involved in over the years, is really around value management. So how do I make sure I get the value from the investments that I make in technology? And this is a classic one where you want to get to a point where you can prove the point. You also want to get to the next bit where I can see the outcomes from this. And the outcomes from this are something that we're going to be working on. And the data that we're gathering globally from this is something we're going to be working on for years. Even within, so if I look at just the researchers who have been involved in this, there's multiple PhDs running in parallel in terms of the data we're generating and the stuff that will come out of that and the things we can do with that. So we're standing up teams at the moment in collaboration with Science Foundation Ireland, and it's specifically looking at, and it's that, so Rosario talked about it, it's the crossover between, so epidemiology, public health, data science, infection science. How do these things fit together? How do we work together? And how do we blend that into public health policy now that we've introduced new digital capabilities that didn't exist?
But I think that's the bit that Rosario mentioned that I particularly noticed is Rosario talked about multidisciplinary, multi-professional approach. And it showed to me that approach, it reminded me of what you were saying about, the medical profession look at index cases. It's centralized around an index case, an index patient, and actually you've given them an app that is the complete opposite to that, because you have to do it from so is there a capacity for a lot of different systems, whatever, like the medical profession has always worked in this way because index patient is the way to do it. Actually, is there another way to do it? If you're talking about, so what are we learning across different disciplines and functions, not just in terms of delivering better healthcare, but delivering better public services in general? So, and how does technology allow for those kind of disruptions?
Well, so so the interesting piece is when you introduce a constraint into any system, you've got to respond to that. So the constraint was to say we can't know that. Now, what can we know? Yeah. And usually what happens is, so to go back to what Colm was saying, in the normal course of events, if we had have done the analysis piece, we would have never got started. Like we'd still be in an analysis piece and nobody would have said yes to anything.
But it's that point that Rosario is making as well, is that contact tracing is not an app. It's a process. It's a system. And so on that basis, it's that analogy that we would use in technology all the time. Don't build a technology application or system to replicate a poor process. If there's maybe, because of the technology, you can disrupt the process, which is the best you could possibly do without the technology, index patient control. Maybe this is a better way of doing it in light of what you're saying about those trade-offs that you have to make between public health, economy, education. I'm not going to go down the liberties route, but whatever, you know what I mean?
Yeah.
But I'm asking.
Absolutely. I think also considering a public health perspective is also crucial to understand what is the rates of people that download this kind of application that actually could be the optimal rate for be sure that the contact tracing is working correctly, because right now in Italy, with a rate of downloads of 10% of the target population, the system sent something like a few hundreds of alerts of people infected. And even if the rate was suboptimal, because the colleagues, the epidemiologists from the University of Oxford identified the download rate, the optimal download rate to be roughly around 60% of the target population. Even if our rates of download are suboptimal, the system worked, identifying, right now the app was online in the 15th of June. And right now we have 5 million Italians with the app. The system sent few hundred of alerts, and we identified 62 right now, 62 infected people, stopping 2 outbreaks, 2 small outbreaks. So my point of view is that, yes, of course, we have to understand what kind of rates of download could be the optimal rates. But actually, we have to start to build our trust, as you say, speaking with the population, listen their doubts about about what is happening around their lives. And actually, it's starting to be interesting also, as this kind of system. It's not, as we say more times, it's not only an app. Also, it created and strengthened an infrastructure of connection among professionals.
I think that's one of the challenges that I particularly noticed in terms of what you were saying. So you've got to reach a certain amount of critical mass.
Well, Joan, can I jump in on that one?
But I know you want to.
I know, because like this common theme comes up, right? And this has been a bugbear for us for a long time. So the 60% number came from Christoph Fraser in Imperial College in Oxford, right?
Yeah.
And the 60% number was this magic, because we still, and like every team globally is being bashed with that number as the target. There's, as far as I can see, there is no target, right? We want to get as many people as possible. But one of the interesting things with the way that the app is adopted is it spreads through existing social graphs. So I download it, I share it to my friends, I tell them about it. So then I'm connecting to people I already know who are more likely to be my contacts.
Social to do what social does best.
Absolutely. And so it works. So if the only people who ever installed it were the people who were my contacts, it's like washing my hands. I protect you, you protect me, because we wash our hands.
Yeah.
We protect the people we're in contact with directly. But then at a population scale, and I think Fraser's the research there, and he's coming back with more stuff on it, is that if your only intervention, that goes to what you were saying earlier, Rosario, this is a systemic response.
Absolutely, yes.
If your only response was that, then you need very high, but it works at any level. And that's been the research that we're kind of focused on, that this can work at any level of adoption.
I get that. I guess the bit I wanted to move on to beyond the 60, not beyond the 60%. So I can understand, obviously, the more people using it, the better it is. But if it saves one life, that's great. But I guess my point is, the challenge in the overall context of what we're talking about is how technology can, address problems like COVID-19. It's how technology can actually overcome any kind of global challenge, whether it's a global pandemic or climate change or whatever. We come back to this fundamental issue of trust. And what breaks my heart is the number of people who will give out and complain about their privacy on a COVID tracking app and give out about it on Facebook.
Yeah.
The irony, leaving that hanging there, that they're sharing far more information on a social media platform that could, Mark Zuckerberg could probably tell you where everybody's been for the last 24 hours as well, and who you've been talking to and where you've been at. But it's somehow we seem comfortable to trust there and not to trust on stuff that really matters. And as a sector, we have work to do. And I think it was pretty great that you got, I think you're fondly calling them Gapple these days, Google and Apple.
I'm not. I refuse to use that word.
Okay. So Google and Apple. Colm, what can I say? How was that for you?
It was great. I mean, they had dedicated teams on their side that were working on this. There were challenges because they were building it as we were trying to use it. So, the very early versions, there was lots of issues. They didn't quite work. We would then get a version working and they would change how they implemented it. So it would break what we have. You'd go around that cycle quite a few times. But it's also one of the really hard problems to do, like the Bluetooth proximity detection. So I think getting them involved, they were the only people that could solve it because they were the people controlling the handsets and the OS level. So it had to be them. So it's
my trust of them.
In terms of trust of them.
Yeah, as I say, a lot of people are skeptical or cynical around trust around large technology groups with loads of information about all of us. I think it was great to have them on board. And I suppose, what do you think? I mean, you can't speak for them, I suppose, in that sense, but have we learned anything more in terms of that level of collaboration? Do you think, were they responsive at the start? Was it hard to get in there? Was it a really, were you pushing open door? Come on, Gar, spill.
Yeah, so one of the interesting things that happened, this is the global Irish diaspora. So the VP for Android is a guy called Dave Burke, who went to UCD and grew up in Dublin.
All right.
So when he found out that Ireland was involved in it, it was like, hey. So it works at that scale, and that we could plug in. But the interactions, because we were up and running and ready, and we were aggressively looking for this, and we were working with them, the relationship has been great. And I think it's been an ongoing one. So it's not without its wrinkles, but both Apple and Google have supported us, and both directly supported us. So we're straight into the product teams. We've got like product teams both locally, kind of at a European level, and then straight into the product teams who are kind of based in headquarters. And they have gone, I mean, I think if you think about what we have gone through, and like this has been an insane, like everybody forgot about their families, forgot about weekends, forgot about everything, forgot about the clock. It just, like, there was just this crazy dash to try and get somewhere. The guys in, like, who are building it in Apple and Google have been trying to support multiple teams who are doing it in parallel at the same time. And like, hats off to them, because they put a huge amount of effort, and like, it's a personal sacrifice piece as well. Like we're looking at each other and we're like, I feel tired. Like they're on these calls all the time as well, and it's running around the clock. So I think it shouldn't be underestimated, the amount of effort they put into it and the rationale for it, because they saw that this was their role, was they controlled a piece of critical infrastructure, as in the mobile device, and they were best placed to respond to this in a way that could help their users. And that was the motivation and the driver around it. I think how it's been recast and people talking about, oh, this is more surveillance, and this was done in a very different way. And this started with the privacy people in Apple and Google getting a handle on what could be done and looking at it from that perspective first, and done in a way that, like, when we looked at it first and when it was presented first, it was like, whoa, this isn't what we're like, nobody signed up for this. And that was driven, like it was public health and epidemiology people going, no, this isn't the way it works. This is, but again, it's that mindset shift of moving from one to the other. So I think the relationship has been good, and it's ongoing, so it's not over, and we're feeding back in.
Yeah,
it is something that, as this is a global learning system now. As each group is figuring out and gathering data, we're feeding it back in, and this is going to be something that cycles over the next, hopefully not for too long, because these things should all, like, I mean, they all come and they're time bombed. So 3 months after the pandemic is declared done, we wind it up, shutter this thing, and it's gone. There's no reason for it.
I think that's the thing, in terms of, again, to Rosario's point, and I guess, Colm, from a NearForm perspective, I don't know to what extent you guys have done a huge amount in public health before, but, this is one problem. And I think technology is going to provide solutions for, other public health challenges that we've got. And certainly, to Rosario's point around behaviors and behavioral change, not just in hands, but in terms of how people interact with their GP now, the knock-on effects in terms of other appointments. So there are, how does innovation in technology address, public health, and in this situation, it's been a global pandemic, but there are other opportunities on the back of that. Rosario, where do you see those coming from?
This is a very serious question. Sometimes I ask myself, why technology? Why it's so important? How we can use it? How we can identify the better solution for our needs, and so on. What I think, considering a public health perspective, is that, of course, as was previously said, sometimes the technology born using a system strategy for developed technology. When we consider the system strategy, we also consider the many nuances of the human beings. In these many nuances, when we develop technology, when we develop new solutions, we have to consider also different way to approach the people. For instance, how we can explain before answering to your question, I would like to share just a fact. How we can justify the different rates of downloads of the contact tracing apps in the different countries. In Italy, we have the 8-9% of the targeted population. In other countries, it's roughly the 40%. Maybe communications, identifying the cultural nuances of each subgroup of population is something that is related to the public health. But going to your question, if we have to consider how we can use technology to enhance sound behavioral change, it's a very complex question, as behavioral change per se, for its definition, is very complex. If you have a whatever habit, bad habit, you know how hard is it change your habit. So if you would like to do something like this, big like this, considering a population scale, your question is very hard. What I can say is that we can use technology to stay close to our patients, to give them a possibility. We have to embrace this kind of technology, considering a system way. We have to integrate the new solution in our systems, in our modus operandi, you know, in our everyday practice, not only as a research project. Everything starts from research. I am, first of all, a researcher. I try to give to my colleagues in different fields of the clinics some answers to their questions mainly. But the point is that we have to integrate the technology that often we already have to our daily practice. For instance, our self-isolated patient at home, why do not consider to use very simple applications such as video calls and something like this, integrated in the daily care path of our patients? It's a mindset of the professional, of the individuals, but this is also something that is concerned. This is something that is
You're dropping
important.
in and out. I just need you to stay closer to the microphone.
Oh, sorry. This is something that is referred to the individual's mindset of the different professionals, but also to the system, because system have to think a way to normalize the use of technology in the daily life. We have to normalize the new solution in our approaches. Okay,
so I want to, Colm, kind of started there with you as well. Like, obviously, this has been, is this your first foray with the HSE?
It is.
Will it be your last? That's a terrible question. I don't mean that. What I mean is,
hopefully not.
I think there's been a huge challenge over the years. I worked in the digital hub down there for years when I was with the Irish Internet Association, and there were loads of, you know, small businesses in there trying to break in to the health service in Ireland, who had really cool applications and services that they were trying to get into the HSE. And some of them very much along the lines of what Rosario was kind of alluding to there in terms of applications for self-management at home. And most of the time, they gave up because it was too hard to get into the HSE. It was easier to deal with a hospital in London. It was easier to deal with a hospital in Australia than it was to get through this procurement process within the health service. And I understand absolutely, and any taxpayer should understand a rigorous, you know, public procurement process. But there are times when it gets in our way and it stops us from being as innovative as we would like to be. So from a NearForm perspective, do you see, you know, you guys have obviously taken a lot out of this experience. It seems Gar has a lot of work for you for the rest of the year, but where do you see some more of the opportunities in relation to public health and the kind of stuff that you guys do?
I think there's a lot of opportunities. The challenge of public health is that whole concept of change. Like, the problem with introducing technology into a lot of public health scenarios is people don't like change. They don't want to do things differently. They don't want to do a video call with the doctor. They want to go and see their doctor. So I think technology can definitely enable services, but it is about how they're introduced, and it is about that trust aspect. You know, there's trust violations with manual processes, but when it's with a digital process, they get a lot more media attention, and people, as they should. But I think it's going to be a slow process to get people to a point where they're happy with more and more digital services. But I think it should be viewed as digital services enabling, as opposed to we're going to replace everything with digital services. Because I think that's where it often goes wrong. People try and come in with a big bang solution that replaces everything, and people just don't want that level of change at that rate. So I do think I think it'll move there, but it's going to be a slow process. There, you know, you see with all these things, none of them move that quickly. I mean, this has been an exception, but it's been very much an exception. In general, this is not how it works.
Gar, from the inside, HSE perspective, do you think they'll do things differently going forward?
Lost your audio, Gar?
I know, I think he's just not saying anything.
Sorry, yes, I'm here. I've got two ways of muting myself, just to make sure. Um, I think the challenge with this is that if you've got a solution in search of a problem, you're in trouble. And for a lot of organizations, like, so if you're a startup who's got a super idea, that super idea lives inside of an existing system, and you're looking at systemic change. So your problem is not that your solution doesn't do what it says it does. It's the problem of which bit of the system needs to change and adapt in order for that to work. And that's, so if you look at the health delivery system in Ireland, which is the HSE plus GPs plus out of hours doctor services plus everything else, it's where does it fit? Like, there was a great piece of research done by, it was a PROACT in Trinity, and it was an EU Horizon 2020 program. And it was looking at management, self-management and self-triage for, oh God. So it was for people with multiple, so if you've had chronic heart and diabetes and something else, and you were in an at-risk age category. So it was like complex stuff that they were trying to do. And it was using devices, so medical devices at home to measure blood pressure and everything else. But they didn't they looked at everything from the ground up. So it's the usability of the technology for the audience that you're touching on, right? It's the integration of this, and what does it mean from a health delivery perspective, which is who's going to do it. It was the payment and the business model around it. Who pays and how does it work? And that changed. So they were looking, so they ran here, they ran in Belgium, they ran in Italy. And what they're looking at is they're looking at different systems of health delivery. So you might have a solution that doesn't work well here, but does work well in Belgium, right? Because it fits into the payer model there, or it fits into the way healthcare delivery is done. So I think from a startup perspective, you have to look at the ecosystem and where you fit in the ecosystem and how that works, and what the business model is around it, and not just I guess
I didn't really want to take it from the perspective of the startup trying to get in, but more about have the HSE, what have they learned from this in terms of the capacity to open up and do things differently? But I'm not going to force you to answer that question.
I can answer a bit of it. Is that we're like, there's a huge piece of work happening at the moment, which is reflecting on all the stuff we've learned about COVID, about what worked and what didn't. Because, like, I mean, the HSE has the largest workforce of any organization in the country. My
sister's working it.
By any measure, right? And so you're moving large portions of that population home to work from home. So what can be learned from doing that, right? And what do we like? What do we don't like? And the bits we don't like may be things that are nothing to do with technology, but it's actually managing a distributed workforce. Again,
I didn't really mean to talk about the distributed workforces and the work from home. Yep. I meant really, I guess, it's just this more idea of, you know what, we've got a problem, we can build a solution, we can do it quickly if we all work together. The government departments get regularly chastised and criticized for not joining the dots. I think one of the things that you guys have done together is almost put together the most beautiful Seurat pointillist painting of dots coming together to make sense that I have ever seen. So on that positive note, Paul has told me.
Can I answer that one? Because I think that the learning, and it seems very obvious, right? So you put a bunch of people together and you give them the mandate to go and do it. They go do it and they're successful. And then we look at other projects and figure out, well, why didn't that work there? And most of the time it is, and it's either intra to that organization or extra with, because it's depending on somebody else. And it turns into this culture of and people just are risk averse once it gets outside of that. When you apply the pressure of a pandemic, then that changes things. But how do we translate that into business as usual activity? I don't know, but it is an open question.
Yeah, and I guess that's the cultural learning that I was trying to allude to, you know, and there is this sense that day, and I hate using this term when the pandemic is over, because, you know, I think we're all going to take a bit of this with us for quite some time. I don't see any end on the horizon exactly, but there's a sense that people will gravitate back to how things were before, and actually there are certain things that have come out of all of this that we want to keep, and a lot of those things are more cultural than they are and behavioral than they are system. So it's good. Look, all I can say is congratulations. I look forward to the movie. We've lost Rosario, but I think I've lost Rosario. I can't see his name across the top anymore. But listen, before I wrap up, Paul will fire me from ever moderating one of these again, unless I remind everybody that there is the next IVI webinar is on the 27th of August, which is actually just next week. I'm clearly not moderating it because it's not in my diary. And I have another, I don't think I am. Anyway, it's mobility payments technology. innovation, and that is next week, next Thursday, the 27th, for anyone who would like to dial into that. Thank you, Colm, Gar, for your services to humanity, and particularly in Ireland over the last 4 or 5 months. Likewise to Rosario. I look forward to the movie. And Paul, thank you very much for having me back again. Have I forgotten anything?
Oh, you haven't. That was excellent. Thanks a million, Joan.
Everybody for listening in. So, hello.
Yep. Thanks very much, guys. It was a great session, and I think everybody, got something great out of it, and well done. I think it was a fantastic job. So thanks very much for participating.